Part 7 of Module 6, End-of-Life Care. End-of-life care, palliative care, and hospice care will be covered in this final chapter for the course. End-of-life care relates to the support and medical care given during the time nearing or surrounding a resident's death. Such care does not happen in merely a moment. Terms are palliative, hospice, and postmortem. Palliative care works to manage symptoms, not cure the disease. Goals of palliative care are to control symptoms, reduce suffering, prevent side effects, maintain the quality of life, and emphasize a holistic approach where you treat the whole person, not just the disease. Hospice can be given in a hospital, care facility, or even at home. It is ordered by the doctor for a person who has 6 months or less to live. This level of care is a compassionate way to care for dying people and their families, using a holistic approach, focusing on the resident and family as a unit. It also focuses on comfort and soothing measures. It emphasizes pain control and symptom management. As in residents' rights, the dying person will also have their rights. They have a right to have visitors at any time. They have a right to privacy, even though they are dying. They have a right to be free from pain and suffering. They have a right to honest and accurate information. They have a right to refuse treatment if it's their wishes. The stages of grief. Grief is deeply emotional. It's a response to loss. It is an adaptive, changing process and usually involves healing in some way. This slide shows examples of Dr. Elizabeth Kubler-Ross's very well 5 stages of grief on death and dying. This is a model that is used across the country. Not all people go through all of the stages. Some may stay in one stage until death, while others may move back and forth between stages during the process. We are not to judge others on how they feel or try to change their mind. Grieving is a personal journey. We are to be a positive and supportive influence. We need to be aware of the staff we work with. They're going through grief, the person themselves, their family, and their friends. Considerations include pain control and comfort, food and fluids, skin, nose, and mouth care, diminished senses, religion and culture, saying goodbye and grieving. Skin, nose, and mouth care are given frequently. We bathe the residents as often as needed. We change their gowns and sheets for comfort frequently. They will likely be spending all day and night in bed or perhaps a recliner when death is very near and impending. This can persist for hours, days, or weeks. More help may be needed when moving a resident due to their body becoming more weak and more frail. There are many concerns, and everyone's cares will be a little different. During end-of-life caregiving, report these observations to the nurse. If you notice breathing problems, if the breathing stops, pauses, if you hear gurgling or rattling in the throat. If you notice nonverbal pain signals, such as groaning, moaning, or grimaces. A clenched fist is another sign of pain. Report nausea, vomiting, and diarrhea. If the resident requests a visit from a spiritual leader, let the nurse know. Inform the nurse if the resident has expressed fears of dying. When family or visitors ask for updates on the resident's dying process, direct them to the nurse. If visitors are needing accommodations or meals, also talk to the nurse. When residents are passing away, we are very tactful and we are very welcoming to guests to stay and bring them food perhaps or coffee and arrange a space for them to grieve and stay close to their loved one. Considerations to keep in mind: do not isolate or avoid residents that are dying. Keep their rooms softly lit and peaceful. Speak normally and describe the care that you are performing. Use alternative methods of communication along with your cares. Gentle touch is a way to let the resident know you're there if they are nonverbal. Listen more and talk less during your care. Do not judge or try to change personal beliefs of the resident. Spirituality can be a big part of the dying process. Other comfort nursing interventions include providing incontinence care promptly, turning and repositioning gently every 2 hours minimum, giving oral cares per unconscious oral care technique, as you'll learn in lab. It is more soft and less likely to cause discomfort. Providing ice chips or cool water if the resident is able to use that safely, and keep their mouth moist. Lubricate the lips with Vaseline or chapsticks. Keep the nose and mouth also moist. These cares are more than twice a day. They are as needed and with repositioning. Frequent linen changes, gown changes are for comfort. The mouth can become very dry when breathing, and mouth breathing, when that's possible, can be very uncomfortable. Just think of yourselves having a dry throat all the time. Sometimes the dying resident has difficulty breathing, and it alternates from slow and irregular to rapid and shallow. This type of breathing is very common in the dying, and it's called Shane-Stokes breathing. Be careful as you move and reposition residents. If their breathing stops because you've rolled them on their side, then maybe you need to be careful about changing that position to that way again. More nursing interventions. Do not force residents to eat or drink. Feed residents slowly as they are able to. Encourage fluids. Elevate the head of the bed to make breathing more comfortable. Adjust blankets for temperature changes. Often someone that is approaching death runs a fever, and so we wish to just keep light bedding on them. Change the gowns and sheets frequently. I've said that several times, and also continue to provide for private visits when family arrive. All care will be adjusted based on the resident's declining. The body may slow down quickly one day and the resident becomes unconscious, and they may have periods of responsiveness after that. Remember that hearing is usually the last sense to disappear. Do not say anything inappropriate around dying residents or their families. For your information, some signs of approaching death: we see cyanotic, pale, or darkening skin or mucous membranes, cold skin, mottling, which is skin that looks kind of like it's been bruised. There's some type of color change usually, heavy perspiration, and fever. You may have been wondering what signs indicate that a resident is going to die. At times there are signs, and other times there are no signs. Mottling during the dying process occurs when the heart is no longer able to pump blood effectively and blood flow throughout the body slows. Mottling can happen and it can reverse, but if you are caring for someone and you hear in a shift report that they are modeling, I would just encourage you to find a time if a nurse can show you what that looks like so you know what to look for, because it is different in different people. We would like to remind you of the place and time and moment surrounding the end of life. Respectfulness for the residents, family, friends, and all who have been in the life of one who has passed is expected of us. This includes yourself as the caregiver, and your feelings do count. To help with staff awareness, an image may be posted for staff as a reminder that someone is near dying or has recently died in the facility. This may be part of staff communication and it's quietly addressed. Keep in mind as you carry yourself in the unit of those around you. Postmortem care is the care performed after death. This care is completed to maintain dignity of the body and also ensures the body will be ready for transportation to the morgue or funeral home. Cares include providing the body a complete bed bath, incontinent care, oral care, and an occupied bed change as necessary. Before performing post-mortem care, be sensitive to the family needs, the friends, who is still in the building. They may wish to stay with the body for a while to say goodbye and to grieve. Post-mortem care is done on their schedule and not ours. Keep valuables and essential items near the body, but not on the bed. Continue to knock and maintain privacy when entering the room. When someone has passed away, we typically do start to refer to the person as the body. However, until they leave, we still practice the same privacy. Ways that staff can cope with the death of a resident can include expressing your feelings and sharing memories and spending time with the people you love. Many facilities allow staff and residents to participate in memorials or services, or maybe even to take a day off. This will conclude the sixth and final module for your hybrid CNA online content. Please speak with the instructor if you have questions about this class. We thank you for joining in these PowerPoint lectures, and good luck on your final exam and at state testing.